So at this point, there's no reason to test somebody just because somebody in the family has myeloma or monoclonal gammopathy. As I said, even though the risk seems like 2 times, think about how uncommon the disease is. So the chance of finding something is very small. Second is, we are not going to do anything about it at this point. So I think the research needs to advance further where we have some viable options for intervening, at which point screening would make sense.
They don't screen
No, at this point, no. But in terms of, there's a lot of research going on in terms of trying to understand what are the triggers for progression and whether we can do anything to change the natural history of the disease. Whether it be an intense, short duration of therapy or something, small dose, long term, all those are different paradigms being looked at.
You did say that if it's found sooner, it's better. So that's, I guess, where I'm confused.
So I may have been misunderstood. There is nothing to show that the only place where we know that it actually makes a difference in the outcome is patients with very high risk of progressing to myeloma, where the Spanish trial clearly shows that doing some treatment seems to make people live longer. Outside of that, there is no evidence to suggest it changes anything. So as I said, there's slightly higher possibility, but it's not high enough that we would actively screen everyone. Again, we are talking about people developing this in their late 60s, right? That's the average age. And, for something with the low risk of progression, you don't want to give somebody something to worry about for the next 40 years when you're not going to do anything about it.
Maybe I could add just something. Let me use a concrete example. If you said Lou Gehrig's disease is familial, and you said, well, what's the risk of Lou Gehrig's? It's 1 in 10,000. But you have a double risk, then it would be 2 in 10,000. So you take 10,000 members from the family, and that means one of extra them. But the 9,998 are going to be clear. So statistically, it's a double risk, but absolute is almost minimal increase. And that's the case with this. So that's number one. The other comment I wanted to make is we don't really know with clarity what, if any, exposure leads to myeloma. Talking about chemicals and pesticides and radiation. And I know some of this is covered, like with Agent Orange and some of those things. But the reality, it could come from a simple cold, because of what we know from these genetic changes, and Leif did all the seminal work in this. When you kind of look at that, you can do almost like DNA archaeology, and we know most of them are just little typos or hiccups that occur during a normal immune response. That's kind of something that's happening on those cells at that stage of their maturation. So I think it could be a simple cold, it could be a sore throat or a toenail, ingrown toenail, that just gives the signal of inflammation and the cells slip a little bit. Okay, there's a standard recommendation of not to use the shingle vaccines in cancer patients. There's a new vaccine that was just approved that is inactivated. So I think we're gonna see more of that. Until we get that approval, all patients who are on immunosuppressive therapy, and I know some of my colleagues would argue everyone, but at least in our practice, anyone who's on proteasome inhibitor or daratumumab, we're putting them on acyclovir. If, for whatever reason, and unfortunately, someone gets the shingles, that's like a super vaccine. So if someone has the shingles, the value of the vaccine after that would be pretty limited, because a vaccine is just like an attenuated form of the disease. So, but until we know better, we're saying no shingles vaccine that is attenuated for patients, and let's use acyclovir. But I think very soon we're going to start using the other one.
Well, I mean, I did the acyclovir, but like for my husband getting the shingle, because it's a live virus, he put it off because he didn't know my condition. Like
it's very unlikely. It's mostly the virus that you have in your body.
So like he should still get his shingle shot.
He can get the
vaccine,
vaccine,
of the age. Yeah. And then MMR, you still do it 2 years. And then flu shot, they still recommend.
So I've looked at that because it's a very common question. Patients with myeloma should get their flu shot. Their efficacy is about the same as that of the general population, which is in and of itself not very good.
Okay. And
but everyone, in general, when I get my flu shot, everyone has to get the flu shot here.
And then can you, I heard if you get the individual, I'm into reading, I guess, a little bit. The individualized flu shot doesn't put preservatives in, but if you go to pharmacies where they add preservatives, is that true? Or
I get into a lot of conversations with my friends about this. I say, don't waste your time. Just get the standard flu shot, okay. And that probably would be good enough.
Okay.
So the standard recommendations, you should get them. Definitely, at the time of diagnosis, we definitely tell everyone to be updated for all vaccinations.
Here, bring the mic up just a second.
Real quick,
Right.
on that vaccine, even if you're not the age recommended, they don't make it lower because you're a myeloma patient, even though you're remission?
N-
Or
n-
just go by age?
Do you? I don't. I just go with the standard recommendation for that. So specifically to your question, if he gets another stem cell transplant, that by in itself should not have an impact on the osteonecrosis of the jaw. A lot of the times it's just the initial, the adequate debridement of all the dead tissue and make sure everything gets covered and healed up well. That is the most important thing that in terms of management.
The osteonecrosis is obviously a very unwanted outcome from these drugs. It seems to be not class specific, so people who get Zometa will get osteonecrosis, but now in the clinical trials, people who get denosumab will also get osteonecrosis. The reason for this, we think, is when you think about it, the mandible, so it's a very important bone for animals, and we're kind of the most evolved of them, but that we use it for fighting and for chewing. So the mandible has to be an incredibly strong bone. And so it has very little of the spongy form. So that sponge-like bone in the inside. So it's mostly the cortex on both sides and a very, very narrow space in between. Some patients, when you have myeloma growth in the mandible, they'll experience a numb chin. So you have some numbness in the chin, and that's just because there's so little space that anything that impinges on nerves or arteries, will cause problems. So what happens is when you tip off the balance in favor of bone formation, those channels that take the blood supply to the mandible. So that's why it mostly occurs in the lower part of the mandible. What we tell patients is you can do dental cleaning, you can do fillings. The things we worry about more are extractions, so something that creates a socket. But what it is, the osteonecrosis is a chronic infection of the bone and it's osteomyelitis. So it's a vascular osteomyelitis of the mandible. So that's why debridement, antibiotics, and sometimes it takes years and years, but the stem cell transplant would not affect that. It's just the order of the letters with Greek designation. So one of the very common misconceptions, people say, oh, it's gamma, so it must be G. It must be SG. I just gave a lecture to the residents yesterday about this. Gamma is just gamma. So in the gamma globulins, you can have an IgA, you can have an IgG, or an IgM. It's just because they went alpha 1, alpha 2, beta, and gamma. So it's just a natural Greek progression. And the M spike, the M does not mean IgM. The M just means myeloma or monoclonal. So you can have an M spike that's IgA, IgG, or IgM. And that gets confusing too.
Again, just to add to that, not all myeloma proteins go to that gamma region. Some of them actually stay in the beta part of it, especially if you have light chains or IgA type of monoclonal protein. They don't necessarily go into the gamma part of that curve. Not for Muggus patients, but patients with high-risk smoldering myeloma, one trial has shown improvement. So the standard of care has not changed. Even now, those patients would be just watched, and only in clinical trials should there be any kind of intervention. So patients with Muggus, absolutely no treatment, just watch them on an annual or every other year basis. Patients with smoldering myeloma, we watch them every 3 to 6 months. And if they are at high risk of progression, we should be considering for clinical trials, but not outside of clinical trials.
It's kind of interesting that sometimes people have what looks like Muggus, but the protein causes problems like amyloidosis. And in those cases, we do treat them. And often we get really good results with the suggestion that we can maybe cure those patients if we treat them. Well, certainly it looks like daratumumab is being evaluated in the frontline setting. And so, yes, CAR T cells will not be frontline for a while because of the toxicities. And the checkpoint inhibitors, definitely not for a while until we figure out how they work. The ends of those curves are the survivors.
Well, that was a comic relief. So if I hear your question, right, sometimes patients ask, what happens if myeloma can't be controlled anymore? Was that the question?
Yeah, where does it typically end?
Yeah. So for most patients, there tends to be a slowdown of bone disease. So whatever bone disease one gets to the beginning and maybe through the first few cycles, that doesn't change much. And myeloma just ultimately ends up taking a person's energy away. And so it's harder to engage in daily activities. Patients who unfortunately have no more options kind of become more dependent on being, in a recumbent position, laying down. So I sometimes would describe it as a process where, you would slowly turn down the dial of a volume of a stereo. That's kind of how we see that. We don't see, fortunately, in most cases, a very dramatic change in other things. And it becomes pretty self-evident to the person. Now, one of the things, and we don't talk a lot about this, but one of the things that we see is when we end up running out of options is just usually that more of a peaceful process, but it's more a gradual decline. And we pay a lot of attention to managing pain, but I don't tell patients, oh, we're going to see more pain because this is coming. Usually we don't see any major changes there. More than anything is that energy, and that can come then with kidney failure, a few other things, but that's how usually things happen.
You can certainly go back to Revlimid since the myeloma cells were not refractory, and especially with you saw all the information with the various combinations that we are using. So any combination that contains Revlimid would be reasonable, and obviously with time you will have more and more options too.
One of the things that's very important for the Revlimid and the pomalidomide, as well as the proteasome inhibitors, is that sometimes these drugs don't work in an all-or-nothing phenomena, and it's a little bit of a grade. We have learned that these drugs hijack some of the normal cell metabolism things that cells do and make them kind of die because of that. So one of them may be putting enough pressure that the cell kind of doesn't like it and dies, so there's a signaling of dying that we were talking about. Sometimes that's not enough of a push, so you use another drug and it pushes and it still doesn't do it. Sometimes we put them both together, so we can see situations where someone who was not responding to Revlimid now is given Revlimid and Velcade, for instance, and now the disease responds. So they use the analogy of it's like if people are trying to open a door that someone is pushing on the other side. Sometimes one person has enough power to do it. Sometimes it has half the power, can't do it. But if two of them do it, they can overcome that. One of the things we really are trying to develop is, can we get some assays, and this is part of what we're testing in the research lab, that will tell us whether Revlimid is pushing or not. Because you could imagine that someone could go on Revlimid, carfilzomib, and Dex, and the carfilzomib could be doing all the pushing, and one is on Revlimid without necessarily needing it. So that's one of the things we need the most.
Dr. Fonseca didn't mention some of the interesting research that he's done that shows that Revlimid kills cells by oxidation. And if you take an antioxidant, that might protect the tumor cells. So he often recommends patients not take antioxidants. The Revlimid kills through oxidation. So if you take an antioxidant, it's like taking an antidote. No.
So, and if you're my patient, I know one of the things we would say is, don't take high doses like of vitamin A, or I'm taking this antioxidant supplement. It doesn't mean you have to change your diets, because there's antioxidants in blueberries. But we don't want people to think, oh, I'm going to take antioxidants to be quote unquote healthier, because it's like taking an antidote for the chemotherapy.
Does that apply to other IMiDs?
It applies to IMiDs, and it probably applies just as well to anything that has to do with proteasome inhibitors and maybe steroids too.
Probably does apply.
Well, it turns out vitamin C is a pro-oxidant, and we've always mocked people who use vitamin C, because there's a lot of people that are out there. I'm a quote-unquote naturopath. I'm going to use vitamin C. I'm like, really? And vitamin C can be harmful to the kidney in someone who has free light chains that are high. But some people are doing some research, and formal, academic research. Maybe there will be a future for oxidants, mixed with some of these drugs. I have never been impressed with turmeric. I've seen a lot of patients, and I know especially a lot of patients in smoldering, because you do something that, it's somewhat benign. I can't remember, honestly, ever seeing a protein level go down with turmeric. I'm sure it happens sometimes, but I've never seen it. Have you?
I have not.
No.
So daratumumab targets the CD38 on the myeloma cells, but also the CD38 on the normal plasma cells. And so it makes all of your immunoglobulins, all your kappa and lambda light chains, everything goes low. And so patients are also at risk for myeloma patients are always at risk for infection, but especially when they're taking daratumumab combinations. And it doesn't really matter if you're a kappa or a lambda or what kind of patient you are. No.
A kappa-derived therapy?
What it does do is you may see a small M spike around 0.1 or 0.2, which is you're actually seeing the daratumumab in your serum.